We're nearly there, so I'm going to hand over to our chair for today, Ashley James from the CSP. Thank you.
Thank you, Ali. Good afternoon, everybody, and welcome. Yeah, so as Ali said there, my name is Ash James. I'll be chairing today. I'm currently the Director of Practice and Development at the Chartered Society of Physiotherapy. I've previously been the Head of Education for Connect, so it's nice to be back amongst friends and colleagues. Workforce is a huge priority for the CSP at the moment, so it's great to be here talking on this. So just as a bit of background, Connect Health has been running the Change webinar series since July 2020 with a really broad range of topics from chronic pain, long COVID, FCP, education and quality improvement, health inequalities, and unwarranted variation in mental health. So a really broad range of topics. Today's topic is on workforce capacity, as we've already mentioned, and we've got a really impressive lineup of speakers, and you can find their full bios on the webpage. Each presenter is going to speak for about 7 minutes, followed by an immediate question or questions, and then we'll take the majority of the questions at the end. So please do post your questions in the Q&A as and when they pop into your mind. So I'm just going to open with a few words about the workforce in general, because as I've said, it's a huge priority for the CSP, and the workforce needs to grow and broaden to meet population needs, and NHS policy needs to meet these demands sustainably. In particular, we recognise that the CSP, to help the overall system, we would be well served improving the rehab workforce and capability specifically. This needs to include increasing the ratio of support workers to registered staff, and investing in the non-registered workforce. So using the principles of safe delegation, increasing the employment of exercise professionals and sports therapists, health coaches, being creative about how we use and deploy students, as well as investing in the careers and former patients who want to volunteer. That's a really important part of bolstering the workforce. In terms of the registered workforce, obviously we multi-professions have a key role, including physios, around overseeing and supporting that non-registered workforce that I mentioned, as well as we know, providing that holistic evidence-based assessment and treatment, as well as leadership and integration with other pathways throughout the system. The good news is, from a physio point of view, that there's no shortage of people wanting to be a physio. We now see about a 7% annual growth in physiotherapy, or students coming into the physiotherapy profession each year, with a relatively low rate of attrition of 1 to 2%. And the other good news is that in the main people stay in the profession, and the fortunate thing for physio is we do have many choices of sector to work in. That's where the good news ends for my bit, because there is some bad news, unfortunately, around workforce, which I'm sure you're all aware of. In spite of clear need, the NHS isn't capitalising necessarily on this growth to bring in the staffing numbers it needs to deliver the goals. We can note, and it's echoed in other allied health professions, that regarding the attrition rate, 50% of that occurs within the first 3 to 5 years of working. There's work to do here. At the CSP, we're looking at preceptorship models. We're looking at how we implement our career framework development model to help support early years clinicians. The NHS long-term plan wants additional roles in primary care, anticipating the needs of people with long-term conditions, providing an urgent community response to prevent unnecessary admissions, getting people out of hospital quicker, not to mention ambitions to vastly improve access to pulmonary rehab, cardio rehab, stroke rehab, and pelvic health rehab. But even before the pandemic, staffing levels weren't sufficient to implement these, and now the needs are vastly increased with a large number of the population with long-term conditions and frailty whose health deteriorated over the last few years. So the workforce in these services is horribly overstretched, with an appalling impact on patients and staff. Where staffing shortages is the worst is in services outside of hospitals, which is also where the greatest need is. This, combined with a lack of opportunities, as I mentioned before, means that a significant proportion of those in the NHS are leaving within the first 3 to 5 years. Workforce plans need to result in the expansion of staffing numbers in total, but in particular rehab staffing, and then attract them to retain them by enabling them to provide the quality of care that we know is needed and opportunities to develop and grow as clinicians, clinical researchers, and as workplace educators. All trusts should have a staffing and workforce development plan that is multi-professional and inclusive of the whole workforce. The CSP continues to lobby, and our policy team recently met with Labour front benches where we discussed further devolving money and decision making, targeting workforce plans in areas where rising demand meets staffing shortages, which is often in small towns, allowing employers to utilise up to 50% of the apprenticeship levy to pay for other workforce training needs. Now, I know that's a very brief picture and I haven't painted a very rosy one there. So I hope the speakers will add to it and hopefully start to unpick some of the solutions that we can potentially implement. So it gives me great pleasure to introduce our first speaker, David Furness, who is the Director of Policy and Delivery at the Independent Healthcare Providers Network, and he's going to provide a national perspective. So over to you, David.
Thanks very much, and yeah, really important topic, isn't it? And obviously, I've got, I think, about 7 minutes, so pretty sure we'll have cracked the workforce challenge by then. So we'll see if there's anything left to say. I suspect there might be a few bits and pieces. Can we have the next slide, please? So I think it's important that we set this in its full context, and these are pretty stark numbers, right? So this is what we're looking at in terms of the national projections for workforce across the NHS. So as you can see, we've already got a gap of about 103,000 full-time equivalents across the NHS, including general practice, as of the end of the last financial year, about 7% of the total workforce. And the trends are that if we expect to see demand increasing as it has, matched with the pipeline of new clinicians and non-clinical staff, as well as what we know about people moving out of the workforce, immigration, all the other factors that contribute to that, the gap is expected to get to 9% in a couple of years' time, and that's equivalent to nearly 180,000 full-time equivalents. And then, thankfully, the projections show a decline to the relatively smaller number of 156,000 full-time equivalents by the end of the decade. So either way, you've got something 7, 8, 9% difference between the number of staff you've got and what we think is necessary to meet the demand. There are some particular shortages where you look at really kind of significant areas of service delivery, and Ash highlighted some of the implications of that as well. But general practice is a clear pinch point where you've got this absolutely horrifying projection that if trends continue as they are, then you're looking at virtually 1 in 2 GP posts being vacant by the end of the decade, and that would clearly render sort of unsustainable the model of service delivery that we've got, and a large number of nurses. Also that shortfall is very considerable, kind of nearly 37,000 again by the end of the decade. And one stat that I would bring in that we weren't able to include in the slides, only came out a couple of days ago, is that record numbers of nurses are actually leaving the NHS as well. I think 40,000 resigned in the last year. There's some suggestion that people are leaving the health workforce altogether, and some of that is to do with financial pressures that are seeing people look to take up better paid jobs in completely different sectors, retail, hospitality, and there may be people moving out of the NHS into other kind of perhaps less demanding roles, but still using their nursing skills. So you've got a pretty bleak picture. And what does that tell you? I mean, it tells you one thing, is that you go to any kind of NHS discussion at the moment, and what you hear is something that says what we need from government is a fully funded workforce plan. And then they go on to tell you about all the things that aren't possible in the absence of that plan. Well, we haven't got a plan. We may get one from government, but what this tells me is that regardless of how good that plan is, there's a lot of things that are going to happen differently over the next 5, 6, 7, 8, 9, 10 years than they happen at the moment. So what does that mean? That means really focusing across a range of areas, doesn't it? Almost regardless of what you're doing and where you're doing it across the NHS or the independent sector. It may also mean doing less with less as well as more with less. We need to look at the skills mix and the potential to bring in staff who are easier to train to do different tasks that are currently carried out by people that it's more difficult to recruit. We need to look at obviously the pattern of immigration. We need to look at the pattern of the kind of the workforce, the education piece as well, in terms of the number of people that we're actually training domestically as well. And of course, we need to look at technology, although I do occasionally feel as though that's sometimes viewed as a bit of a panacea. And the answer is to put lots of different tech in the hands of clinical staff in a way that might actually make their jobs more difficult to do, not easier to do. And it'd be interesting kind of views from the rest of the panel on that. Just two thoughts, though, in terms of how we might be able to kind of come to some solutions, or at least frame this debate in a way that helps smooth things forward. One is that this is clearly incredibly politically important, right? So one of the big themes of politics in the last few years has been an effort to essentially reduce immigration into the UK. That was a key part of the sort of post-Brexit political environment, was that we would have a sort of more robust immigration policy. But we're seeing already the new Secretary of State and the Secretary of State, Steve Barclay, who was in post for just a few weeks over the summer, really pretty clearly saying that we need to increase immigration from overseas in clinical roles and other roles where people are working in the NHS. So it's incredibly important, and it's able to overcome some quite considerable political barriers. That's number one. Second thing is almost kind of linked to the Prime Minister's very clear desire to see an economy that grows more quickly. Productivity in the health sector and in the NHS has been growing more quickly than productivity in the rest of the economy. So by about 1%. So we've seen actually higher productivity gains in health than we have elsewhere. So people that you recruit into health actually become really productive in an economic sense. And that is, I think, an argument that we haven't kind of made clearly enough to government about how we can move those, how we can actually contribute by growing the health workforce to a more productive economy, both within health itself, but also in terms of the treatment of people who are currently falling out of the labour force because of their lack of access to healthcare. So that's the national picture. Can I have the next slide, please? Thinking specifically about the independent sector workforce, and my organisation has about 100 different organisations in membership. It's occasionally a bit of an afterthought when we talk about the size of the NHS, but IHBN members in the independent sector delivering both NHS funded care and private care employ over 150,000 people in England. We hear as well from our members that workforce is their absolute top priority. So I think 84% of our members told us that it was their single biggest priority the last time we did our industry barometer. That's out and open now, and we're expecting a very similar result. And what we're seeing in response is something that, again, I think that the sector has been criticised for in the past, which is not making a sufficient contribution to training. We know that that lots of our members are doing that already, and that many more are planning to do more in terms of apprenticeships, training, development programmes to tackle workforce challenges. And expecting to increase training for clinical staff over the next 5 years. Could I have the next slide, please? What does that mean in practice? It means lots of different things, actually. So since September 2020, over 4,000 junior doctors have been trained in the independent sector. That's going to become increasingly important because we've seen a massive rise in the use of independent sector providers among certain key specialties. So to give you an example, 45% of cataracts in the NHS are now carried out by an independent provider. What we need to do is make sure that that service change is matched by changes to training pathways, and essentially both insist but also enable the independent sector to play a full role in training the doctors, nurses and other clinical staff of the future. Our members are looking internationally as well, and we've done some brilliant work with a fantastic organisation called Talent Beyond Boundaries to provide employment for refugee health workers, and we've got people working across the country in independent sector providers, and we're really proud of that. And our members are currently supporting over 1,500 apprenticeships, and in fact the single biggest nurse apprenticeship programme in the UK health system is run by an independent provider. So there's a lot more to do, but there's an awful lot happening. And that's something that we are really proud of, but also want to kind of see increasing. And then my final slide next, please, before I hand over to other panelists. So one of the challenges I think we've got is we've got a rapidly changing NHS structure at a point where workforce is probably the single biggest challenge facing the system in order to enable it to respond to the challenges that we know we've got in terms of the backlog of care in the community, in the hospital sector, in diagnostics, you name it. I think we really need a whole system approach to workforce, and one of the challenges that we encounter in the independent sector is that it's not always easy to engage as well as we'd like to with ICSs. It's not been, I think, clear how we can work with ICSs to get a kind of shared view of the workforce across a system and make sure that independent providers are fully enabled to make that contribution to training that we know our sector wants to do. And I think there are some big challenges as well in terms of how we use ICSs, or how ICSs can actually manage to implement kind of proper system level workforce plans when a lot of the answers are national and even in the realm of kind of high politics in terms of workforce supply. And I think that is an unresolved tension, particularly since we know that there are still powerful kind of organisational provider interests within the NHS that sometimes make it more difficult to collaborate. So that's, I hope, a kind of useful overview of what we think is the national picture, and then obviously we're picking up various different aspects of the debate over the next few minutes.
Thank you, David. That was excellent and really good. And we've got 2 minutes until the next speaker is on. So I wonder if you could just flesh out that last point for me. I've got a question. So you were talking there around the ICS's responsibility and workforce planning there. So what do you see as some of the threats and opportunities potentially? I know you mentioned some of them there, but could you just flesh that last idea out for me a little bit?
No, it's really good question. I mean, some of the opportunities are actually kind of back to some of the points you were making, Ash, as well, about actually doing something that's more tailored and more relevant to particular localities, and making sure that you're seeing things in the round, and of course kind of working with local authorities, because if you've got an issue with things like housing for healthcare professionals, that may well be a topic that you can tackle most effectively by collaborating with other agencies in a local area. So I think that there are huge opportunities, and I think the ICS vision at its best really is one in which you can bring all the different kind of relevant interests and contributions to the table and have a really honest conversation that says, how can we get the best for patients in our system with the resources and capability that we've got? And I think, the challenge then is to sort of make sure you've got all the right organisations at the table. And that's something, that's very close to our heart. We know it's not the most important thing that ICSs will be thinking about, but that interaction with the non-statutory sector, I think, will be key in developing that. And then, as I say, you've got two big overarching dynamics. One is that you can't at ICS level magic up many more training places for doctors or nurses, because those decisions still have to be taken at a national level. We've got what I know will be a kind of difficult integration of Health Education England into NHS England, so it could be a while before that's kind of firing on all cylinders, because those kind of national mergers are always really tricky. And then you've still got the problem, which is you've got powerful NHS foundation trusts and trusts sitting around the table, and I think it's not always apparent to me what levers do you pull as an ICS if you don't feel like you're getting the level of kind of collaboration and contribution that you want to have in terms of making sure you're using your scarce health workforce as effectively as possible across your area of responsibility. So lots of opportunities, but definitely some challenges to resolve.
Yeah, brilliant. Thank you, David. That was really, really interesting. And more questions to come on that topic, no doubt, I'm sure. I'm going to move us along to our next speaker, who is Michelle Waite. She's the Assistant Director of Development and Employment at NHS Employers. And Michelle is going to talk to us about best practice ideas in recruitment and retention, particularly from lessons learned in nursing and midwifery. So thank you very much, Michelle, and over to you.
Thank you, Ash, and thank you for having me today. If next slide, please. So I'm going to go straight into it. So there are currently a number of factors why recruitment and retention are vital to us at the moment. As we've heard, we're very reliant on international recruitment to cover vacancies, and this has been shown by the numbers of increase in the nursing stats, which was about 23,000 last year, compared to just over 25,000 of UK trained joiners. The pandemic, has had a positive effect on the numbers of individuals going into training, but we have seen this decline this year. It's also highlighted the numbers waiting for treatment and the staff experience, again, as we've heard, which is not always positive in health and social care. So having different routes into your organisation at different levels will give you a range of options to deliver care pathways. The labour market's really key. We've seen an initial sharp fall in employment during the first wave of the pandemic, and then there was a rapid recovery in employment figures in the latter half of 2021. However, that recovery appears to have levelled off, and the number of those not looking or unavailable for work continues to rise. So the signs are that the job turnover remains well above pre-pandemic levels as well. And obviously in healthcare it is rising. This is likely to be fueling the record number of vacancies and labour shortages, and as organisations struggle to backfill posts from the lessening numbers of who are out of work. And as a result, unemployed workers face more job vacancies that match their skills than they would have done before the pandemic, which means in the healthcare area, we have to work harder to attract that talent to come into us. And then finally, the government's levelling up strategy and education reform is aiming to realise the potential of every person in every place. And they've committed to give all students the skills employers need and putting employers at the heart of the skills provision, along with overhauling the funding of courses in line with employers' needs. And we've recently seen that with the removal of the BTEC level 3 in health and social care, which is a real clear pathway into our area, which has now been taken away. So we need to ensure we have a voice in this reform so that pipelines into health and social care are not restricted by the changes taking place. Next slide, please. It's really important when a vacancy arises that you don't just put the previous advert out. It's useful to think about the other potential opportunities, such as apprenticeships, as well as the traditional degree. And Cambridge University Hospitals worked with Anglia Ruskin University to develop an apprenticeship pathway which enables students to gain healthcare assistant experience while studying part-time to achieve their nursing degree. All those appointed onto the programme are offered permanent healthcare assistant posts with a guaranteed registered nurse post upon their registration. And as well as developing a sustainable nursing workforce supply, the strategy provides significant career progression opportunities for all age groups and skills levels. Also, know your audience. Not everyone knows about NHS jobs, and so it's crucial that you think how you attract people from different communities and age groups. For example, Mid Cheshire Hospitals NHS Foundation Trust and East Cheshire NHS Trust use social media to join and connect with local voluntary and community groups. They use words such as job or work in the chat and proactively share local NHS employment opportunities. They offer to visit groups to explain the roles available and provide one-to-one support to help individuals into employment. And between November 21 and June 22, they've registered 105 people into their recruitment support service, and 36 of those have received job offers. Sharing key information. We NHS employers undertook a survey for NHS England following a large healthcare support worker recruitment campaign, and we found that applicants really valued as much information as possible about the role, as it wasn't clear what duties they'd be doing. So some of the trusts have now produced videos which are on their website, which can be linked to the advert to give the applicant an understanding of the role. So it's really beneficial to get your communication teams involved if you have them. So when they're sharing local stories, that links can also be made to your vacancies and share the different opportunities that are available in the locality. Next slide, please. NHS employers have found that the gap between interview and start dates can be really long due to the pre-employment checks, and so it's important to keep the successful candidate engaged. Share information about the team, a clear induction timetable, development opportunities to ensure that they know you are still really keen on them to start and to retain them. We've seen with the healthcare support worker role that having a buddy who is experienced and the new worker can discuss issues, which really helps with new recruits and is again likely to support their retention. And having supervisions and one-to-ones are key for picking up issues quickly and ensuring the individual has a good start. And I'll share a example of that from our London region. Next slide, please. Having a healthy culture in NHS organisations are crucial to ensuring the delivery of high quality, safe and effective patient care. Understanding how staff perceive culture and want to be treated will help to create and implement a collective leadership strategy and to develop compassionate, fair and inclusive working environments where all staff can thrive. Maggie Oldham took on the task of turning around the culture at Isle of Wight NHS Trust. The NHS staff survey identified it as one of the most improved trusts. The task they faced was really serious. They had 8 areas that were inadequate for safety. So she knew the focus had to be providing nurturing, compassionate leadership, highlighting the value of connection, empathy and empowering people, and by single-mindedly keeping people and staff indicators as the driving point and doing everything from a perspective of making this a better place for staff, they have started to see results. Approximately 1/3 of the workforce in the NHS are in the late stages of their career, and what people want may change over time. As an example, Nottingham University Hospital launched a late career hub hosted by the innovative Care for Knots platform to support staff across the ICS. The platform provides resources for late career healthcare professionals, their managers and mentors. Another area key for retention is flexible working, as this supports staff to have greater choice in where, when and how they work, and should help them achieve a better work-life balance. The Oldham Care organisation has developed a job description and role profile for Band 6 midwives working 6 hours a week. This offers increased flexibility to the midwives that might otherwise consider leaving their roles. And flexible retirement, that allows people choice over when they retire and allows them to continue working in a different way. Norfolk and Waveney Health and Care Partnership piloted a legacy nurse programme which aimed at retaining potential nurse retirees so they return or remain in practice and share invaluable knowledge and skills, plus provide pastoral support, professional advice and guidance to colleagues. And my next slide just details some of those resources that I have mentioned today, so you can have a look at them in more detail. Thank you, Ash.
Brilliant, thanks Michelle, really useful and lots of insight there. I do have a question for you, but I'm going to save it until the end. I'm going to let it marinate because I'm going to keep us on time.
Okay, thank you.
But I've got a good question and I will save it to the end. I'm going to move on now to our next speaker, who's Ben Wanless. He's a consultant MSK physio in St George's University Hospital, and he's going to talk to us about digital enablers. Over to you, Ben.
Thanks, Ash. So yeah, as Ash said, I'm Ben. I work down in South London at St George's NHS Trust, which is a fairly big NHS trust. We deliver MSK services across the borough of Wandsworth, which, if you're not from London, it's about the size of a decent city in the UK. I've specifically been asked to talk about the digital enablers that may assist with some of these workforce issues that are being discussed today. I only have 7 minutes, so I'm going to focus on one particular aspect of this, which is going to be really around the cost effectiveness of digital solutions for MSK care. Could we go to the next slide, please? So you may or may not have seen a graph like this. This is from a systematic review about 10 years ago now. It's specifically looking at low back pain, but they looked at all the different treatments that exist for back pain. And actually, whatever you throw at people, osteopathy, self-management, chiropractic care, physiotherapy, to all the other weird and wonderful things that you might do, people get better. And that's just to highlight what we're talking about here, and one of the potential reasons why digital is seen as a bit of a solution. So although this was back pain, there's lots of other evidence that MSK conditions do get better in time. Now this is particularly about acute conditions, and some of you might be thinking, what about persistent pain? And yes, that poses a different challenge, but this is essentially the context that we're talking about here. Can we go to the next slide, please? So why digital? So often the big thing that gets spoken about these days is that the internet is ubiquitous. 88% of the population have a smartphone. So if they've got a smartphone in their hand, which is essentially a very powerful computer, can we deliver some of the care that traditionally has been given face-to-face via that medium? And then also many people suggest that we can deliver standardization of standardized care via a phone, which we haven't been able to do in the past. And of course, then there's the assumption that by providing something digitally and taking out the human clinician, we will save money. Next slide, if you wouldn't mind. In addition to those kind of quite obvious things, digital interventions have several other advantages, because they can incorporate features that improve adherence to medication, exercise, such as coaching and education and self-monitoring, but also give us the ability to remotely manage. So as clinicians, we can see what our patients are doing. Now, if we can go to the next slide. Now, this is a bit of a busy slide, and there's a different version of this with some nice fancy animations, but this is literally all the systematic reviews that exist around the effectiveness of digital health interventions for MSK care. Not broadly, but they look at different things like back pain, OA, etc. So there's quite a lot of evidence out there. We're not going to focus too much on that today, but we're going to look at the cost effectiveness, if you wouldn't mind going to the next slide. So I was asked to talk about the digital enablers for workforce capacity. So obviously, if we're thinking about workforce, we've got to think about, do these digital interventions deliver what they're proposed to deliver in a cost-effective way? Now, interestingly, none of those systematic reviews I just flashed up in the previous slide looked into the cost effectiveness. And also none of them looked at a broad range of MSK conditions. This one from a couple of years ago did look at a broad range of MSK conditions, but didn't look at the cost effectiveness. So if we just go on to the next slide, I'll talk you through a bit of work that I'm doing. So I'm doing a systematic review into the self-management of MSK conditions. Because of the digital agenda, I decided to break down the first lot of studies into just the digital. So this Prisma flowchart here is the digital studies that we included in our systematic review. And if you look down the bottom, there was 104 included. Only 3 of them looked at cost effectiveness, and they're the ones that we're just going to briefly skip through in the next few slides. So if you wouldn't mind going to the next slide, please. So out of the 3 studies, weirdly, they all looked at OA, and they were all in different countries to the UK. So this first one looked at OA in the knee and the hip in Sweden. And it was, you might have heard of the Joint Academy, and that's what they looked at. And they compared it against just standard care against the Swedish guidelines for OA. So what I've tried to just show here, actually, before I go into what I've shown in the results, it's important to say that it wasn't blinded, it wasn't randomized, and there's lots of other biases in there. So for example, the patient self-selected whether they went for face-to-face care or whether they used the digital intervention. And what I've just tried to show here, and again, bearing in mind we've only got 7 minutes, we can't delve too deep under the bonnet of the cost of and costing analysis they did. I just tried to represent a a few snippets of ultimately what they showed. So you can see here that their contact time was a lot less when you provide someone with digital, which is obvious, and that obviously has a cost associated with it. And then they looked at the more broader healthcare costs and then the societal costs, and you can see up there that the digital was a lot cheaper ultimately. Then they did much more of a robust analysis, and they looked at the quality adjusted life years, and then the incremental, I always forget what this one is, the incremental, I've got it written down somewhere, the incremental cost efficiency ratio. So as you can see, I'm not a economist or an accountant, but what I will try to explain with this is that the face-to-face intervention costs £705 more per participant to get one gain in their outcome. Their outcome they used was a simple numerical rating scale. So to get 1 point better in the numerical rating scale, it costs £705 more face-to-face. Now the next slide it just represents a slightly different trial that was done in Holland. I've tried to represent the results in a similar way, although it was reported a little bit different. It was an RCT, this one, but there wasn't any blinding, and there's obviously a few other criticisms if you went back and read the article. But again, you can see, although not as obvious, the digital intervention was slightly cheaper in terms of the intervention, the healthcare costs and the societal costs. So interestingly though, when they did a sensitivity analysis, and they did that in quite what I think is quite a robust way, none of the savings that they saw were statistically significant. Now if we move on to the next slide, this is just the third article was retrospective data. There was no control, no randomization and no blinding. I've just made the graph in the next slide slightly bigger, and what I want you to focus on simply is the red bars in the middle. So ultimately what this is, and I would recommend going back and looking at this, is that if you deliver face-to-face care, it's more expensive, and if you mix it, and a lot of these studies call it blended care, it costs just as much to give them face-to-face and the digital. The red bars on the far right are when you just deliver digital. So that's a graphical way of showing that it's cheaper to deliver digital. And then if we just go on to the next slide, I just want to briefly talk about real world data. So research evidence is great, but it comes with its own issues and problems. Real world data can solve some of those problems, but also comes with its own biases. So this is just some work that we've been doing in South West London, which shows a reduction in, for example, physio appointments, GP appointments, and prescriptions. And there's another example I've given for a product called AHP Suffolk, which have shown some savings by digitising their triage processes. We can talk some more about that hopefully in the Q&A, because I'd quite like to compare the difference between research and real world data. But in summary, if we go just to the last slide, what I've hopefully shown you here is that digital solutions do offer potential benefits, but unfortunately at the moment there's a distinct lack of evidence that they actually do provide an efficacious intervention and that they're cost effective. Interestingly, also there's a complete lack of digital inclusion considered across all of these studies. So my view is that services should continue to use digital and innovate, but we've got to get better at publishing some of these results in a really robust way so everyone can learn from those. And then my last slide is just my contact details if you want them.
Brilliant. Thanks, Ben. Really great insight there, and it's good to look at some of the detail of that. I do have a juicy question for you, but again, I'm going to save it until the end to make sure that we stay on time and everybody gets their presentation time. But yeah, thanks for that very much. The next speaker is Dr. Chris Tomlinson, who is a senior sports physician at the English Institute of Sport in Lilleshall. He's also the Chief Medical Officer of British Gymnastics. And Dr. Tomlinson is going to talk to us about redefining and diversifying the workforce. Over to you, sir.
Thank you, and hi everyone. I'm going to talk about diversifying the workforce, but I'm also going to talk about accreditation standard setting. And I think that one of the things is really important, unless we're to be replaced by Ben's computers as clinicians, is that we make sure that we do our jobs as well as possible. And I believe passionately in this based on my own experiences. When I started working in a musculoskeletal interface team back in 2005, I just had a diploma in sport and exercise medicine. And I remember the first day, my first patient being observed by a new colleague, and I had a wrist osteoarthritis, which I'd never dealt with before. And I had to go back to my car to get my Society of Orthopaedic Medicine book to revise anatomy, to then inject this poor lady's wrist, which I did successfully. I've also seen many of my advanced practitioner physiotherapist colleagues also struggle within an advanced setting, even though they had the requisite qualifications at the time to do the job. If we could just grab the next slide. So this is all about raising standards in care. And being a doctor, I'm going to talk more about how we can make sure that people like myself 17 years ago, a GP with an extended role, are able to do the job properly and be properly qualified. I will, of course, talk about the Health Education England pathway for physiotherapists and other advanced practitioners and how this aligns. Next slide, please. So what is a GP with an extended role, who used to be called GIPSs or GPs with special interests? The Royal College of General Practitioners defines it as a GP who undertakes, in addition to their core general practice, a role that is beyond the scope of GP training, and because of this requires further training. And the Royal College of General Practitioners is sending out GPs with extended roles in many different professions, including dermatology, for example, rheumatology, general medicine. So the RCGP doesn't really want to do anything other than provide a framework and wants interested parties to then provide standard setting for GPs. And so the Faculty of Sport and Exercise Medicine has developed collaboratively with the other main medical multidisciplinary team bodies working in the space, that's the British Association of Sport and Exercise Medicine and the Primary Care Rheumatology and Musculoskeletal Medicine Society, a GP with extended role accreditation pathway. It's now endorsed by the Royal College of General Practitioners and the British Society of Rheumatology. And essentially what it is, as you will know from the NHS England Advanced Practice Framework, is it's a formal process to show knowledge and competency. We see this as providing two routes for general practitioners working with extended roles. The first is those who've worked for a very long time in musculoskeletal clinics, and they should be able to show that they match the required standards to continue working in that role. The second is new general practitioners who want to develop an extended role career will be able to follow a training pathway or a variety of training pathways to lead to an endpoint. We have aligned this as much as possible with NHS England's accreditation process, with the asterisks telling me that, interestingly, it's difficult to fully map over general practitioners' competencies to advanced practitioners' competencies because the general practice training does not involve getting an MSc, and therefore, in effect, NHS England will look on first contact practitioners working in general practice as being more highly qualified than general practitioners. Next slide, please. As part of this, the faculty has developed a baseline knowledge test for people entering musculoskeletal medicine. Again, developed in association with our colleagues, baseline test which enables, on passing, the applicant to become a diplomat member of our faculty. And our faculty looks now to represent a multidisciplinary workforce via our diplomat section. You do get post-nominals, and the exam can be mapped against sections of the HEE Advanced Practice pathway. It's been a good career builder for the advanced practitioners within my own team, and 300 people have now taken and passed the exams. Slightly annoyingly, the physiotherapists who've taken the exam have scored rather better than the doctors. Next slide, please. I'd just like to make the case for medics within the musculoskeletal MDT. We are expensive. You know, I apologise for that, but we earn the GPs earn the same as neurosurgeons, I guess. I think, therefore, often when we talk about savings to be made, the doctor is the person that will be pushed out of these settings. But actually, I think doctors add a lot of value and a lot of soft value. We are well used to managing complexity, uncertainty and risk, and I've found that my colleagues are often not, because that's not what they're used to, whereas for general practitioners in particular, that is bread and butter. We routinely handle diagnostics and prescribing. We have medical knowledge about drug interactions, managing comorbidities, good training in the biopsychosocial approach, although I know that is now a big part of advanced practice. We have our roots and our context in primary care, and I think building trust from general practitioners sending patients into these services is really important. And unfortunately, secondary care consultants often respond better to medical consultants and GPs than they do to advanced practitioners, which is something that over 17 years we've tried to overturn. So we're making big strides there, but there's still more to be done. The next slide, please. We've talked a lot about expanding the musculoskeletal workforce, and I've been asked to just make some comments on this. Next slide, please. I think it's been mentioned, but crikey, don't we have to get the basics right? Don't we have to get good rehabilitation? I bore my patients to death. I bore certainly the people sitting in with me from time to death. I have a mantra, which is essentially there are only 3 ways of treating MSK problems. There's non-invasive conservative treatment, there's injections, and there's surgery. And this first bit is the big bit, and it's the bit that's either very complex or very simple. I'm talking on a course at the moment, and I say, what is the baseline treatment for nearly every musculoskeletal condition? And thankfully, they're now parroting back to me, good physiotherapy. Do we get that right? I don't think we do. Do we have a workforce shortage? That's what we're being told. So we need to integrate aligned professionals such as strength and conditioning coaches and exercise professionals, along with osteopaths, chiropractors, etc. We need to develop clear pathways and processes for those clinicians so that we know that we're getting baseline good treatment. And again, and it's been spoken about by my colleagues, we need to support workforce retention by allowing both promotion and job satisfaction and an ownership of the system. Last slide, please. It breaks my heart that nationally we don't seem to have any workforce planning. Everything's said to be local, and everybody relearns how to invent the wheel. We should know roughly how many doctors, physiotherapists, strength and conditioning coaches, exercise professionals should be part of an ICS type service. We should be able to do that and then change things a little bit locally. All the information that we have is not national. All the good work is often hidden on different CCG's websites, and pathways are not generally managed nationally, although I know that there is work to be done with this. I think we need to invest in the multidisciplinary leadership to actually push things through, because when we empower our advanced practitioners, they empower system change, and we need a way of learning from that. We need to partner, and we've seen that there's plenty of work available for everybody. Therefore, this isn't a bun fight to get to see who influences things. We need to work together, particularly I think the people like the CSP and the Faculty of Sport and Exercise Meds, to collaborate on building good conservative multidisciplinary care, because we need a voice shouting for the multidisciplinary team to government and for government. Thank you very much.
Brilliant. Thank you very much, Chris. That was really insightful and very, very, very useful. Again, I do have a question that I will hold till the end, because I want to keep us on time, and then we'll have 15 minutes for questions at the end, so plenty of time. Keep your questions coming in on the chat if you have any. I know some have been rolling in. We're going to move on to our final speaker now, as I say, before we move on to our questions at the end, and it's Andrew Cuff who is a consultant physiotherapist and current head of MSK at Connect Health, and he's going to look at the productivity curve and delivering successful group consultations. So over to you, Mr. Cuff.
Excellent, thanks Ash, and it's great to follow on from Chris. As a diplomate member of the faculty, it's great to hear that physios are doing so well on the exam. So I'll be talking about kind of productivity and innovation, largely from a community perspective, from a MSK perspective, and obviously hopefully providing a kind of clinician's voice to the panel. If we move on to the next slide, I'm going to touch upon group consultations, but largely as an example of thinking about doing things differently. What we're seeing across healthcare is just essentially this mismatch of demand and capacity, and I think we've kind of gone into some of the roots of that already as a panel. And from a community perspective, if we look at the kind of waiting list at the moment, there's about 1 million people waiting for community services, of which about 300,000 are rated to MSK conditions. So it's a real problem. And this didn't start during the pandemic. This was happening pre-pandemic, and the pandemic has just amplified this. And as we continue kind of as part of our recovery, we're seeing that patients are more complex. We're seeing that health inequalities are widening. And at the same time, we have this workforce supply issue. Now, whilst that's a challenge, the opposite of challenge is opportunity. And that's where I think things such as productivity, innovation, and accountability really come in. So move on to the next slide, please. So I kind of touched upon this concept of accountability, and depending on where you look, you get a variety of different definitions. An interesting one from an investment banking definition of accountability is to have responsibility for honest and ethical conduct towards others, whereas the English dictionary describes it as being held responsible for the results obtained after performing a given activity. And I think there's a real role here as clinicians. We think about how we interact with the resources we've got at our current disposal and how we're held to account for doing the best job we can in that setting. So we move on to the next slide, please. And this is kind of largely in focus at the moment across healthcare. So this is from an article in the HSJ following the meeting of a number of trust CEOs, and I think it just really nicely demonstrates the importance of accountability within healthcare, but particularly when we think about workforce and we think about productivity and innovation, and especially at all levels, and particularly when we think about a lack of clarity on who's accountable or who we're accountable to, does lead to kind of problems that then begin to confound and spire. Move on to the next slide, please. And this brings on to the accountability ladder. Now, this is something that I've only recently become aware of, and largely it's used within kind of leadership models to try and develop accountability within a team. But it's really useful to use it as a reflection, as both as a clinician, but also as we consider kind of healthcare more broadly. So you've essentially got a dotted line that sits between acknowledged reality and wait and see. And it talks about kind of two different groups. Below the line, this unaccountable reactive response to problems, whereas above the line, we've got this accountable proactive response to problems. However, before we can get to accountability, people need to feel like they are in control. So we need to ensure, before we try and build this culture of accountability, that the clinicians that are working across healthcare feel they're in control of what they do. And this is where accountability and compassionate leadership are not mutually exclusive. As clinicians, we can still work in a compassionate way, we can still lead clinicians in a compassionate way, without necessarily having to worry too much about things such as productivity. They're not mutually exclusive, and that's, I think, really at the crux of how we're going to recover moving forward. And the quote here from Matthew Train, the CEO of BHR, was just really interesting about how if we find ourselves in that victim response too clear or too much, even if it's from good intentions, is that really going to help us recover? Is that going to help us become more productive as we look to recover as a healthcare system? So we move on to the next slide, please. So I talked a little bit about innovation and wanted this concept of group consultations. And as mentioned, when we have a challenge, you have an opportunity to do things differently. And group consultations aren't entirely new. They've been used in primary care successfully for long-term conditions such as COPD, diabetes, some work here from based up in the northeast looking at group consultations within rheumatology. And on a previous Connect Change webinar, we had JP Gownan presenting on group consultations for shoulder pain. Now, when we're looking through how these models are developed, they're still fairly resource intense. And I suppose to Ben's point, there's an assumption that digital care will be cheaper or more cost effective. And similarly for group care, that the same assumption takes place that it's going to be cheaper or more cost effective. But moving on to the next slide. We wanted to test a new way of group consultations, and largely this demonstrates kind of a bit of an overview of the pathway. So as Ben's mentioned, we use a digital front door for a lot of our patients in which they can self-refer. From the inclusivity perspective, they can do that in 120 different languages. They can do it in terms of voice to text. They can do it in a variety of means. Now, for patients that were presenting with what we think was knee osteoarthritis, essentially non-traumatic knee pain, following completion of their PhysioNow self-referral, patients were offered the choice of a group consultation or one-to-one appointment. And we put this in largely in the kind of heights of lockdown. So that one-to-one appointment was by telephone. We started off with virtual groups, and as lockdown restrictions eased, we've moved that into choice around face-to-face at the front door. So patients could either go straight from the digital app into the group consult, or they could choose to go into a one-to-one appointment, and following that one-to-one appointment could still see the benefits of going into a group consult. So whether that be kind of peer support, social support, or the ability to understand or have questions answered that they didn't realise they even had. And that was excellent. We also then thought about kind of skill mix and how do we best utilise that front end aspects of the group consultation. And we ensured there was an advanced practitioner and also an advanced rehab practitioner within that group setting. So it largely became a bit like a one-stop shop. Patients that were could be supported to self-manage. They might go on to have further one-to-one intervention. They might go on to have further group intervention, but also diagnostics could be procured from the group, or the person could be brought back for injection. So largely trying to ensure we make that front end as efficient as possible and ensuring there's choice and inclusivity all the way along the pathway. Move on to the next slide, please. And this is just another example of doing things slightly differently. So in January, we changed the PROMs that we collected as kind of standard across our musculoskeletal services. And some of you may be familiar with START MSK, which is essentially a kind of prediction tool that looks to predict patients' outcome or risk of chronicity based upon their kind of risk profile, whether that be low, medium, or high. Now, as clinicians, one of the things we're really good at is taking on more stuff within our toolkit, taking on more stuff within our consultations. What we're not so good at is stopping things in order to make space for the new stuff. And largely this is where we've been kind of innovating. So if we look on the bottom left hand side here, we can see that we've got medium risk, high risk, low risk. This is based upon about 30,000 patients that filled the START MSK out between January and July. And you can see the majority of patients we see are medium risk and a minority are low risk. Now, the risk across healthcare more broadly is if we overtreat those that are going to get better or have a good prognostic outcome, such as the low risk, because that means the opportunity cost is we undertreat those that might require more intensive treatment. As well as capturing kind of START MSK, we also capture some other kind of baseline clinical factors that we know have an impact upon prognosis. And you can see on the right hand side, if I played around with the dial somewhat, for someone whose back pain has stayed on at work, is physically active and has at least been through higher education, what that does to the risk profile. And you can see that their prognosis is significantly better than the general kind of long-term condition. I'm mindful of time, so move on to the next slide, Ash. This is just to highlight that some things in theory don't necessarily work out in practice. So following the kind of the START MSK introduction, this was a randomized trial that looked at matched treatment. So a low risk, a one-to-one, one-off session, medium risk, a few one-to-ones but closely into groups, and then high-risk groups more one-to-one treatment that was psychologically informed. And what this found, there was no significant improvements in pain or function as an outcome. However, with this available to clinicians, it's important to consider whether there might be implications around clinical decision making when taking alongside other factors which might be modifiable or non-modifiable, such as things like education status or physical activity status. Cool, and final slide, please, Ash, before I give way for questions. It's just to think about that productivity curve. Largely, because across healthcare at the moment, we're seeing a lot of fatigue, whether that be through working, whether it be through change fatigue. And as new ways of working take time to embed, you won't hit your strap straight away. And it's not uncommon when you're looking to introduce innovations that you'll see productivity dip off for a period of time. And we definitely saw that in our group consultations. They weren't as efficient as our previous kind of one-to-one at the front end until we started to optimize and until we kind of really focused on that implementation stage. And change and ideas often fail because of an ineffective implementation stage rather than being necessarily poor ideas. So I suppose as we start thinking about productivity and ways to think about workforce capacity, I think what's really clear across all speakers so far, and I definitely echo it, is whatever we do in the short term now to overcome current problems should align to where we want to be in the long term and account for this. So I suppose whilst we've got a challenging time at the moment, my take home is don't be afraid to do things differently, but make sure you see it through to the end. Thank you.
Thanks, Andrew. Really helpful. And I was going to come to you for the first question, which was about what's the one thing you would like clinicians to take away, but you just told us at the end there. So I'll go back to some of the questions that I didn't ask, and then I do have another juicy one for you, Mr. Cuff. Don't worry. So I'm going to go back to Michelle actually for a question, if that's okay. And I want to understand a little bit more about that local labour market and what can employers and managers do to understand their local labour market a little bit better?
Yeah, thank you, Ash. And can I apologise because I've seen in the chat there is somebody from Scotland, and so this isn't going to answer their question. So I do apologise before I start. But one of the most great tools that is available is something called NOMIS, which is provided by the Office for National Statistics for England and Wales. And it publishes statistics on a national, regional and local level about the population and the labour market. So an individual organisation can go onto that website, look at wherever they want it to be, whether it's their trust site, their integrated care system site, whatever, and they can see what the unemployment is like in that area, where there's inactivity, so it splits it down to age ranges, if people have got caring responsibilities. So what that enables, and there's also about the diversity of the population in that area as well. So what an organisation can do is obviously look at where there are areas of unemployment or inactivity, and they can focus their efforts on that area, whether that be for older people, for younger people, is it students, you know, whatever it is, and actually focus their recruitment activity in that area and try and target their vacancies towards those, you know, people in community. They can obviously ask their local staff as well, how can we reach these people that might not think of the healthcare as a career, and they've got connections as well. So I'll happily put in NOMIS for those people in England and Wales. It's a great tool to use.
Brilliant, thanks Michelle, that's really, really useful. And for that person from Scotland, if we get a chance, I will do a quick overview of the countries from a workforce perspective, if that's helpful. But I just want to get through a few more of these questions. My next question is for Ben, if that's okay. You talked there, you know, really detailed kind of, and that Prisma diagram is really useful in us understanding how much evidence is out there at the moment. Considering the lack of evidence, the emerging evidence, I suppose, in and around digital, what's driving the digital agenda, do you think?
Thanks, Ash. So I think it comes from a good place, and I think I suppose people think about those first 2 points in one of my slides, which is about access and standardised care, and then they don't go deep enough into the cost savings. They hope it's going to work. And I'm not saying that, although there's not loads of evidence for it now, it doesn't mean we should ignore it, but we just got to make the evidence a bit better. So in that sense, it's from a good place. And I suppose people, they have all these constraints like we've talked about around workforce, but they also have budgetary constraints. Our managers in the health service are expected to deliver the same results with a lot less money. So the obvious thing is, okay, humans are expensive, digital is not, which again is fine. What I think I get frustrated by is that we tend to think, okay, everything can be solved by digital, it's the panacea, where actually there's certain elements of a patient pathway that could be improved, and we've spoken about some of them today, but not all of it can be delivered digitally. So we've just got to think a little bit more carefully. And then one other thing I'd like to just say is that I think people, when they think about digital and how effective it's going to be, they just forget, or they don't think enough about how important human relationships are in the delivery of healthcare. And because of that, they just think, okay, why can't we just give this person an app and they'll get better, without thinking about, actually, do you know what, with this particular problem in this particular setting, you do need a human interaction, you need that relationship, and you need that holistic care wrapped around this patient.
Brilliant. Yeah, thanks, Ben. Really, really good points there. Going back to Chris, if that's okay now, with my next question. You touched at the end there of diversifying the workforce, and I think outlined the benefits of what that might be. And I suppose we're all sold, or certainly people in this room, I imagine, will be sold on diversifying the workforce. I think the patients and the public often will still have a very clear idea of what the workforce should look like to them in their mind. How do you think we can educate patients on the benefit of diversifying the workforce?
Yeah, it's a good question, because we're all slaves to our own unconscious biases, aren't we? We all think we know what healthcare looks like, and I certainly would not claim to not have any of those biases myself. But we all work with colleagues who are incredibly passionate, incredibly well trained within their particular area of expertise, who are much better at doing the things that we're not so good at. And I think the way of selling this is to talk about the benefits of exercise and the benefits of skilled professionals who can deliver exercise programs. I think it's about education and explanation, really, and patients who are knowledgeable tend to be much more amenable to getting the best person to treat them, rather than looking at a name or a title.
Yeah, brilliant. Yeah, I couldn't agree more. My next question is quite a simple one, but it's linked to your talk, Chris, but I'm going to aim it at Andrew Cuff, because he got away lightly with the question at the end. And you mentioned a lot in yours, you're talking about good physiotherapy and good delivery of MSK care. My simple but broad question to you, Andrew, is what is good physiotherapy?
Well, there's a question. Thanks, Ash. So I would probably say that physiotherapy is a profession, so it's hard to have good physiotherapy. But particularly when we think about kind of an inclusive workforce, sports therapy, osteopathy, chiropractics, etc. I would say good rehabilitation is probably, I'm mindful it's semantics, but also mindful there's a broader message behind that. Surprisingly, I don't think we really know. And if you look at the evidence around kind of interventions for musculoskeletal conditions, they're all fairly underwhelming. Fairly small effect sizes, and largely, when tested in fairly controlled manners, they don't really demonstrate much improvement. That sounds really kind of gloomy, doesn't it? Particularly as an MSK professional, and we're saying that's a good treatment. But I think it's similar to what I said about challenge and opportunity. I think we need to think differently about care and how we provide care. And there's opportunities there around kind of holistic care. We've been fairly reductionist over a number of years. Think about kind of personalised care, informing, involving the person in terms of what their treatment, what their management looks like going forward. But also just thinking about how we reconceptualise MSK care more broadly. So less about necessarily interventions, but more about how do we give someone value in life? How do we start addressing some of the social factors, really taking that health professional role as opposed to kind of MSK specialist role might be the way forward, and how we support things such as self-management, how we support people to make informed choices and fully understand why they're presenting and why the symptoms are coming at that time. So if I had the answer to what great rehabilitation looks like, I think even what we think is great in terms of progressive, individualized, often based around value goal setting, when we test that and we look at the evidence base, it's still fairly underwhelming compared to where we want it to be. But I think that gives us a mandate to think differently. And one way of doing that is thinking about new ways of looking at workforce, new ways of interacting with people, if that answers your question.
Yeah, brilliant. That's fantastic. Thank you for that, Andrew. For my final question of this Q&A section, I'd like to come back to David, if that's okay, and just touch on something that I think was mentioned during your talk in the comments. I think we're not necessarily touched on in great detail, and that's around international recruitment that can really help with or potentially help with our workforce. And there's a question here from Carol, or a statement with a question embedded within it, is that isn't there a danger that relying on the employment of overseas staff will deplete their own health systems to such that an extent that their governments will ban the kind of poaching of healthcare staff? And I know you answered in the chat, but I thought it'd be worth expanding on in the main session here.
Yes, thanks very much. I mean, the short answer to the question is yes, isn't it? It's sort of actually it's not a kind of magic bullet, and it's something that needs to be approached carefully, and I would say ethically as well. And I think it's something that there's a huge role for some negotiation between governments about kind of what's accepted and acceptable. And of course, we mustn't forget as well that lots of the people who've come to work in the NHS from overseas over the last decade or 15 years haven't been from countries with far less developed health systems. They've been from places like Spain and Portugal, you know, and actually the different political environment has made a difference there. But I do think that's rather different from some of the kind of stereotypes about essentially offering people a better standard of living and then having them leave their domestic health system and therefore kind of leaving it in a worse state. But it is a huge consideration. I know that there are you know, kind of codes of conduct that are rigidly enforced by government, and that's exactly the right thing to be doing. But I think it's definitely got to be part of the mix of solutions that we look at to close the gap between supply and demand.
Brilliant. Thank you very much, David. I think there was some fantastic points made there in the answers, but also throughout all of the talks. You know, we've touched on lots of things there, from digital to the national perspective to diversifying the workforce, all the way through to productivity. So some brilliant points there for workforce. I'm just going to come to you in the order that you spoke today, just to close, and ask you for one thing that you would change that might improve the workforce crisis that we're currently in. And I know there's lots of things, but I'm going to press you for one thing. So I'll start with David, and then if we just continue in the order that we've spoken today. So David, straight back over to you.
So one thing to kind of take away. So is that the yeah. So I guess it's kind of, for me, it's that there's no one big solution here, and actually what we need to focus on is retention. We need to focus on tech, we need to focus on recruitment, we need to focus on growing our own, and a lot of those solutions are within the gift of people running organizations and people working in organizations as well. And I think we are doing ourselves and patients a disservice if everything is waiting on a plan that will never arrive in the form we'd like it to. So let's look at the whole mix of solutions, I think.
Brilliant. Thank you, sir. Michelle?
I was gonna think positive from David, so I would love to see a funded workforce plan with numbers in it, that we can work towards, that ICSs can work towards, and and that universities and colleges can support apprenticeships and traditional degrees with.
Excellent. Thanks, Michelle. Ben?
So someone made a similar point to my answer in the Q&A, but although mine is around, it was about an agreement around standardizing a good outcome. But my I suppose suggestion or want and need would be that we standardize and really robustly support evaluation of real world data when it comes to implementing digital for some of these workforce issues, because at the moment we have to rely on the evidence and the research, and that takes years. And often, you know, the papers I presented today, they're 5-6 years old, and they're talking about text messages and if smartphones become popular. So digital moves too quickly to wait for some of the research. We just got to get better at using population health data in a standardized way and presenting it so we can all benefit from the positive outcomes we are seeing.
Thanks, Ben. And I'm going to come to Chris and then Andrew, and I'm going to ask, because of time, for a 1-sentence summary, if possible.
A national recognised system which touches on the other points of workforce planning, but also of pathways and outcome measurements countrywide.
Brilliant. Andrew?
Mine would be, let's stop over-treating people that have got a good prognosis. And secondly, what are you doing now in clinic or in your service that you weren't doing 5 or 10 years ago? And what have you stopped doing to make space for it?
Brilliant. Very good question to end on. Thank you very much for joining the webinar. It was really great to hear from all the speakers. Please don't forget to fill in the feedback form. It will take you 2 minutes and it really helps improve future events. Other than that, thank you very much for your time and enjoy the rest of your week. Thanks all.